30% of the people who need mental health services in Africa, or maybe even in Ghana, don't get it. So that's like a treatment gap of about 98%. Right, but when you think about it, just think about the number of people with mental health difficulties. 1% of every culture has schizophrenia. What's 1% of 26 million? Are we 26? Are we 27 million? We're hitting. Okay, let's make us 30 million. All right, so 1% of 30 million is about 300,000. That's just schizophrenia. That's just schizophrenia. Another 20% will have anxiety. Even let's combine anxiety and mood disorders. That's 20%. So what's 10% of 300 of 30 million? 3 million. That's 10%. So double that for the 20%. 6 million people. They don't have it all the time. It's episodic. Both anxiety disorders and mood disorders tend to come and go. So this is a lifetime prevalence. So it's not something to be sneezed at. And now, when we take the substance abuse disorders, and they may be, there may be comorbidity. Like one person can have 1, 2, or 3, or 4 mental health disorders. So when we take the people with substance abuse disorders, we're looking at maybe 10% of our population, whether it's tramadol, alcohol, heroin, cocaine, cigarettes, marijuana. And we add that, we're looking at what? We've said 6 million, we've said 300,000, and now we're adding another 300,000. We're getting up there. Not to mention those of us who say we are normal. Those of us who are walking around thinking we're normal, even us thinking. So you will have 20% of us who know we are not normal walking through your door every day. 1/5, 1 in 5 of every one of your patients will have something that you have to be careful of. Because if you are not careful of, it will affect your treatment outcome. It will affect your compliance. It will affect your patient's ability to pay you. It will affect your patient's support system so that they don't even want him to come and see you. Have I made a case? I already knew, that's why you were sitting here. Very good. Okay. So, how do all of us that we've mentioned in this category, how do we get services? That's what our topic is about today. So, most of us, for mental health, will go to church, we'll pray, we'll clap, we'll dance, we'll fast, we'll speak in tongues, and we'll be okay. Then Sunday we'll go for another shot of the Holy Spirit. Do not think that I'm making light of this. This is my own mental health. This is how I keep saying. My faith in Christ, my strong rootedness in church, that is part of what makes me happy. So I know me and a few million Ghanaians is what we do. And a few million Ghanaian Muslims as well, this is what we do. We will not say, we have to give Osei, when we say Osei here, we have to give that to the churches for their great work in mental health. But some of us proceed beyond regular church. We visit herbalists, fetish priests, faith healing camps, as well as state hospitals. We need this. And there's a lot of work that has been done on that that shows that actually people are rational in their choices. They go where closest to services. They go for services which are closest to them, which are most accessible, thank you, and affordable. Okay. Now, in all of the places available to us, there are human rights abuses, sometimes of the gravest kind, which we have to be careful of, which we have to be aware of. Because you know something, as long as you're not in the grave, you and I could be needing those services. And they better be safe places for us. Okay, so this is some work that we did. But I'll come back to this a bit later. This kind of shows the incidence of those of us who say we are sane, shows the prevalence of psychological distress amongst us. And it's about 20%. I'll come back to this slide later. The WHO thinks that around the world we should have sorry, you can't see very well. We should have a mix of services like this. Okay, so at the bottom of the pyramid, most of your services must have self-care. That means at the base, most of us, let's say maybe 70% of us in Ghana, and this is my own arbitrary proportion at the base of the pyramid, I'm thinking we should be able to take good care of ourselves. So self-care services should be right there. Then you have informal community care, so that would be church, the Kwewu have their Kwewu, the Akuapim have their Kwewu, the groups, or Bobobo groups and things like that. Informal community care. Then we have mental health services through primary health care. Then we have on top community mental health and psychiatric services in general hospitals. And then we have long-stay facilities. So where would you fit in the work that you do?
The primary health care, mental health care. Yes, primary health care.
Okay, so that's, sorry.
General hospital, where we do community psychiatry.
Oh, good. So that would be the fourth level. Okay. So, and it seems like as we go higher up the pyramid, more of our patients have severe mental illness. So that seems to be the mix at WHO. So let's look at self-care. Okay, so this is what I put together for self-care, but I'd like us to have a little bit of a discussion on that. So we have healthy behaviors, just like you would in good physical health. Eating, sleeping, avoidance of addictions. So healthy behaviors. Any others? Exercise, yes. Why did I forget that? Yeah. All right. So exercise is one. Yes. Anything else? Adequate hydration, yes. Sorry. Recreation. Oh, I didn't put all of those things there. Okay, recreation. I'll put it in for the next time. Next time I'll look more knowledgeable. Yes. Recreation, yes. So these are all healthy things that we ought to be doing if we know that we're taking care of our mental health. Okay. Avoidance of stress, work-life balance, all of these things are important. Okay. Then I put in easily available knowledge of mental health or mental illness causes and treatment. Because if we're going around thinking that our mental health depends on some spiritual, cases and generational cases and all of those things, we're going to be living in fear. And living in fear is living in bondage. Living in bondage is, that's not how the Lord created us, right? He created us to live in freedom, and when we live in bondage, we become sick. So our people need to understand, that if you live a stressful life, if you drink too much, if you smoke too much, you can get mentally ill. And even if you're born with mental illness in your family, if you live with less stress, you might get away with it. You might just about be able to live a normal life. We need to tell this to our patients and the general public. Then the other self-care, societies can be planned to be stress-free. So you can build houses. I just came back from Norway. Norway is building houses near train stations so that people can just get out of their house, walk to the train station, go to work, walk from there to work, finished. They don't even have to drive. And they are a wealthy society. They're thinking about the mental health of their people. Things don't happen by chance. We in Ghana think that if we just stay, things can just, if we don't do anything, we are going, heaven knows where we are going. We know we will. What is that? And I used to love that song as a teenager. Those suicide days. But how can it be? You have to be deliberate about people's health and their mental health. So you have to build societies that are planned to ease stress. People are waking up, they live in Adenta. At 5, they take off with their children, fast asleep in the back of their cars, to drop them off in school at 6. What is that? And we are the black star of Africa. No, we can do better than that. We are supposed to be the black star of Africa. Well, you guys, when you finish your specialization, you better be thinking about these things. Don't let the psychiatrists get away with thinking mental health is their privilege. It's not. It is for all of you. So we have to plan our societies. We have to have strict laws to protect public from harmful medications. I can walk into any pharmacy and just say, my head is aching, give me tramadol. My bones are aching, give me this. They'll give me. My neurologist told me that my spine is 100 years old. So he then plies me with painkillers of all kinds. If it wasn't that tramadol really made me feel terrible, I would have been an addict today. So I stopped all the medication. I went to see a physiotherapist instead. And most of the days I come. But you know what I mean? We're not protecting the public. We're not. We are not. We've become part of the problem. So having good mental health begins with good public health, good public mental health. So there needs to be messages out there for our people so that they understand their health is their responsibility, their mental health is their responsibility. So that's why the WHO puts the bottom there, self-care. Informal community care, we talked about the church, the support groups, and there are all kinds of ceremonies in the church. Thanksgiving, baptism, harvest, confirmation, marking the stages of life, giving you some rules, fasting, you will come to fasting, and all of that, deliverance and all of that. These are, you know, we might laugh at them, but I would say over 10 million, 70% of Ghanaians are Christian. And out of that, let's say even half of them go to church once or twice a year. Hey, I don't know that we can produce enough psychologists, psychiatrists, community psychiatric nurses to take care of all the things that they take care of. So anyway, those are all rituals that we need. Faith healers and prayer camps, like I said, they're getting the more serious, they're giving the more help to the more serious psychological illnesses and psychiatric illnesses. We'll come back to that in a minute. And then we have our own cultural practices. Why do you think Bojimo became such an important ceremony? The Bojimo. The outdoorings, yes. How do you think? What do they prevent? Postnatal depression. That's what it's for. It's to prevent postnatal depressions. And wherever you have very ritualized ceremonies from the time the baby is born, the care of the mother, the special herbs and baths, and it's all, of course, for the health of the baby and for the mom. But wherever these institutionalized rituals are solid, you have less postnatal depression. There's been some solid work done in Ethiopia about that. So these are really very important things that we shouldn't take for granted as we move into globalization. We should know the things that have kept our societies and know how to modernize them. So the mental health services through primary health care. We have the district. Well, the way it should work is, me, I wake up, I am hearing voices, and I'm worried. My mother should be able to take me and bring me to the medical officer in my district or lab polyclinic or whatever and say, she's hearing voices, so I don't know what has happened. And then you, if you are there, you should be able to say, oh, no worries. Take a good medical history, psychiatric history, social history, and then sort me out with some antipsychotics and give me a therapist. If after 2 weeks nothing has happened, then you want to send me with a letter of referral. Don't just tell me to go to Accra Psychiatric Hospital. Send me with a letter of referral to Accra Psych and tell the psychiatrist to send them back to you, assess, treat, and advise. Bring them back to me so I can manage them. They are your patients. That's the way it's supposed to work. You don't say, oh, it's not you go to Accra Psychiatric. That's what you do. At least 95% of the referrals in Accra Psych are not from doctors. Or they just say, Akemba, Towamba. Don't do that. You should be able to take your patients back and manage them. These are chronic patients. Okay, if I'm going to be money-minded, they will be a good source source of supply of money for you in your private practices. Plus, you'll be helping them live with their families in the community, which is the most important. Better health outcomes. Okay, so that's how it's supposed to work. It is not as well developed because everybody dumps on the primary health care as medical officers and nurses and so forth. And so they don't think that this is their work. But it is their work. And I think we don't give them enough training either for mental health care. So this is an area that needs to be strengthened. In Uganda, most of mental health care lies on the shoulders of primary health care nurses. But I think it should lie on primary health care physicians first. And then you bump them up according to severity of illness. The one thing that I want to say is that there is not sufficient dialogue between the Mental Health Authority and the Ghana Health Service. And that dialogue needs to happen so that the services can be developed between the two of them. So I just want to say it here so that you can push at the meetings that you will become privy to. Okay, now we are at the level of community mental health and psychiatric services in general hospitals. And we have quite a few of them. Who knows where they are? Who's come from a general hospital that has psychiatric services?
We do community psychiatry. They are west. It's the western region.
Northwestern. Western North. Okay. Sefi. Okay. My nephew just got posted to Sefi. He cried. I said, "Share, go. Go and learn about your country and come back." So, okay, good. So Sefi has a community mental health service. Very good. Any other of you? Yes.
Home health center has community nurses who go. I think they have a itinerary. Monday they go to the houses. Then Tuesday they go to schools. They have their schedule.
Okay.
But they are also based in the facility.
Okay, very good. So this is where?
Home health center.
Where is that?
It's on your way to Pram at the Kombaria, you turn right.
Okay. We call it Bong. You call it Bong. It's not Bong. It's Bong.
Boom. Yes.
There are two different communities. Okay.
I think from now, especially in the Boulder region, almost all the district hospitals have a mental health unit. Then the district health directorates also have community mental health officers, some of whom are in health centers and therefore interfacing with the community, whilst those in the hospital appear to do more of institutional care.
That's actually a great model. And then in the whole government hospital, there's a unit, like a 10-bed unit or something. The regional hospital. Not all of them have, yes. Yeah.
We also have one in Tamale Central Hospital. It's even a training unit for psychiatric nurses. And then we have visiting doctors coming from the college here.
Okay, very good. And we set up the WA regional hospital. We set up a ward in the WA in the 90s. I don't know if it's still there. WA regional hospital. It's not there. You've taken our ward. Please restore it. Are you there? I will come. You better have a ward there. We set it have in the 90s, myself, Dr. Hine, Dr. Arba Sebadidi, was a model. They have taken the word. Don't mind them. And Dr. Sebadidi made us hire community mental health officer in each of the 5 districts. You had 5 districts then. Upper West. There are 11 now. Okay, so there were 5 in the 90s. And we used to go up there and give them and supervise every 3 months and help. And because they were there, the chains fell off. Bring medication, and chains fall off. It's reported everywhere. So you want to take care of the chains, get people out of chains, then you bring community psychiatric nurses, you provide them with medication, chains fall off. So please think about that. Okay. And then of course we have at the national level the 3 psychiatric hospitals. And now the 2 major teaching hospitals have functional psychiatric units. So Kolebu we have a brief assessment, we call it a brief assessment unit. The model is that you come, you get a very quick assessment, you get treatment, and after 5 days or after a week, sometimes 2 weeks, then you go home. Then you're linked with the community mental health nurse. And then you come for OPD if you like, or the nurse comes to you in your house. So that's the model that we have in Accra side. And for the first time, the Ghana Health Service, Kolebu Teaching Hospital was allowed to hire 8 psychologists. And I hear Konvadochi is also looking to hire 8. So that's not bad. Okay. We also have an addictive diseases unit in Kolebu. And it's a day center for now. You know, Pantan has like a really strict addictive diseases unit. It's a rehab center. It's a very good one. And then we also have our own pharmacist assigned to us in Kolebu. And we have a very busy OPD. So that's really very good. Then at the very top of the pyramid, you're supposed to have long-term services, right? Long-term stay, long stay facilities. We don't have those in Ghana. We use, well, you'd say the psychiatric hospitals are long stay, but they're not, they shouldn't be. I should be able to go to a specialist hospital, stay there 5 days, 2 weeks, 1 year. No, not 1 year. 1 month at the most, and go back home, so that my relationships are still intact. But there are a few people who not only have very severe psychiatric illness, but they may also have not only the software is gone, but also the hardware is gone. I like to think of it, that there's some brain structurally that's not working, and it's difficult to keep them in their families and their communities. So therefore, you must have those long stay places for them. Also, you should have forensic units that are separate from psychiatric hospitals. So we have special ward in Accra Psychiatric Hospital. But if you don't take good care, they escape, they're back in the community, all kinds of shenanigans can go on. So better you build a proper forensic facility for people who are going through the court system. So those are, I think, what we don't have. We need these long-stay facilities. We need all our district hospitals to have, 5-10 bed units that are brief assessment units for our patients. They come and go and still continue to live in their communities. And they are linked with the community psychiatric nurses and the medical officers. In fact, the cheapest kinds of psychiatric care you can have is your medical officers and your community psychiatric nurses going into the community rather than your patients coming to you. So that's something that we should be thinking about. Okay. Then the last one that I wanted to talk about is the assisted living facilities, where, somebody with really bad depression or psychosis can live almost independently, but just with a little bit of care. So you can have one nurse, social worker, or psychologist, whatever, in a home with 8 or 10 patients who stay. They get assisted to take their medication, to go for their activities. They may have work that they do, which is, is also like a factory job where the factory supervisor is taking care of, is making sure that they behave properly, and they can live quite well and be useful members of society, and then go home to visit and come back. They don't need to be in a hospital for that to happen. So there are all kinds of models around the world which have proved to be helpful to the patient, the patient's family, and to cost saving in the society. So those are some of the things that we don't have in our system. So way forward, what are the strengths that we have as a society for mental health? What are some of our strengths?
Family support.
He said social support. What else?
Yeah, currently we have community psychiatrists in our hospitals who also do home visits. So it's also what we have.
We have community psychiatrists, community psychiatric nurses in our system. We have primary health care nurses that we could train to boost the service. Okay. And then we have prayer camps. And we have CHIPS compounds from where we can operate these mental health services. So I want to show you something that we did. How much time do we have left? About 20 minutes. 15, very good. Okay. So I want to show you something. So we put together a clinical trial of psychotropic medication with faith healing. And what we did was we took some residents in psychiatry every week up the mountains to a prayer camp. We diagnosed properly, did mental state exam, blah, blah, diagnosed, then randomly assigned them to medication or no medication. We ran the study for 2 years. Our theory of change was that with medication, there'd be better health outcomes. The chains would drop off. And we could change the worldview of the camp attendants, because their worldview was mental illness was spiritual. Okay. So, like I said, we would go up there every week with our load of psychologists, psychiatrists, and we had a nurse, we hired a nurse up there to run the study when we went there. And 120 patients in this place at any given time. That's a hospital right there. That is a hospital. 120 bed facility, you know, plus, not just 120. So all the resident patients were interviewed. To be eligible for the study, they had to have a psychiatric diagnosis. They had to be between 18 to 65 years old. They had to speak and understand either Cree or English. They had to consent to participate or to have a family member who would consent for them if they couldn't consent at the time. That they wouldn't have been on any medication at all for 2 months, and they would not have a physical condition which would rule out the use of psychotropic medication. So I had, quite a few people working with me on this one. So never mind the process. We got ethics approval from Noguchi. We did it all the correct way. We even got funded by the University of Ghana. So that's a big endorsement, right? If the University of Ghana says, I'll fund you, and Noguchi says, yes, you can go ahead and do it, then we knew we were covered. So this was a randomized study, like I said. There was, of course, a demographic questionnaire. The primary outcome measure was the BPRS, the Brief Psychiatric Rating Scale. How many of you know this scale? It's a very good scale to use. Just make a note of it. If you Google it, you can have it with you in your consulting room. It's there's an 18-item version, there's a 24-item version. It really is helpful when you're doing like a mental state exam, like on the side. You can kind of use it to help you do your assessment properly. So it was our primary outcome measure. And then we also measured the quality of life. We measured global assessment of functioning and the clinical global impression. These are all very useful scales. The clinical global impression scale, it's like 1 or 2 items. And it helps you assess improvement after you begin medication. Very easy to use and very easy to get on the net as well. Okay, so we saw our patients 0 times 0 when we saw them, then we saw them 2 weeks later to assess 2 weeks later and 2 weeks later until they were out of the study. We had a control group and we had an experimental group, and when we were done with the study, the control group had access to medication if they accepted. Okay. Clinical diagnosis. The major illnesses were psychotic disorders, bipolar disorder, depression, and comorbid substance use disorder. Okay, demographics. Look at this. 200 patients screened, more than, for blood pressure, blood sugar, height, weight, and so forth. For some of them, they were fortunate we were there because we found quite a few people with what's the sugar disease? Diabetes. So we would prepare them for help, yes. And blood pressure, yes. So we got that screening done. That tells you how important it is that you guys need to take over those prayer camps. You need to go in there, work with the guys. Don't be afraid. Nothing to be afraid of in the camp. In fact, we had a lot of prayers on our head when we were working in the camp. I'm telling you. They prayed for us proper. Nothing to be afraid of in those camps. And we had 93 male, 46 female people eventually participated in the trial. Look at this, 108 divorced. That's very sad. No, No, I don't think that's what sent them there. It is a mental illness that sent them there. And it is a mental illness that led to the divorce.
So here, looking at the gender distribution, I was wondering, this is participation. Did we have any data about the actual total population there? And whether it was the males that had a predilection for participating in the study as opposed to women, or this is just to have an idea so that
this is representative of the proportions of patients that were there. So there were more males in that camp than females. Even in Accra Psychiatric Hospital, and all the psychiatric hospitals, there are more males than females. OPD tends to be different. Outpatient care, you may have more females than men because women are kept at home. And they tend to be less violent, so they're easier to keep at home when they're not well. Yeah. So this is very, very sad to say 108 of them had lost their life partners, probably because of the illness. 12 were still married, the rest were single or never married or widowed, or they were widowed. 98 had children, 41 had none. So these were young people and older people who should have been with their families, but the severity of the illness may have led to problems. Look at the educational mix. 11 were in university, 33 primary school, 34 diplomas of some sort, and 62 in middle school. So you could almost say that they were representative of our society, you know, almost representative. So after 2 weeks, if you look with medication, the change, this is the BPRS, the Brief Psychiatric Rating Scale. So this is times 0. After 2 weeks, people on medication are reporting fewer psychotic symptoms or depressive symptoms, and it keeps going down until it's at change score 0.66. If you look at the control group, they've also gone down somewhat, but they kind of stay around about there, whereas these guys keep going down on medication. So the effect sizes eventually after 6 weeks on medication, the difference between control group and experimental group is about 0.43, which is a moderate effect size. This is the kind of effect size you get in very controlled settings of drug trials in the West. So we knew that these are old tested drugs. What we wanted to show was that in a prayer camp setting, you can get them to work, and that your patients would have better health outcomes in a prayer camp setting. So I think we managed to do that. The change in quality of life, you know, the change gone from 0 upwards, not very different after 2 weeks. And then they tank downwards, and then they begin to go up again. And I wonder if we had kept the scores going, if we would have ended up like that. Because when people suddenly come to understand that they are in a prayer camp situation, they are chained, many of them still chained, the quality of their life hasn't improved, even though now they are more aware of their circumstances, then they are much more depressed. So, unfortunately, okay, let's see. We couldn't show in the end that the chains fell off. And, you know, even though you can see a difference, it's not statistically significant. And the reason we think is that we didn't measure it daily. We measured it every 2 weeks. And so people trying to remember how long they've been out of chains for, that didn't really work. And this is something you need to know. Many of the young people there were in chains because they were using substances. And that's what had begun the psychosis in the first place. Many of them on marijuana. And marijuana is like the biggest risk factor for psychosis of all of the medications. So many people will smoke it, nothing will happen to them. But many need not have psychosis, having smoked marijuana. So don't mind the Americans. The fact that they have, yes, don't mind them. The fact that they've taken it off their illegal, illicit drug doesn't mean that it's not a risk, high risk for psychosis. It is still. It is still. So those of you who smoke it, please. Those of you who smoke it, know that you better hide it from your children and your children's children and from your patients. Do not think that it doesn't hold a risk. It is our most risky substance for psychosis.
Yeah, so the issue about legalization, I think even among psychiatrists, there are different schools of thought. And what we learned previously, our previous presentation has to do with the multifactorial, so genetic predisposition. And there is this thinking that, well, it's just, how do we call it, something masking. Whatever be the case, if you are going to get a psychosis, you have gotten it anyway, whether you took marijuana or not. So, but that was the thinking we got from the previous presentation. And then here we are. Yes, a predisposition. Something will trigger it.
So, yes, so you know about genotypes and phenotypes more than I do. And I would say that not every genotype is expressed phenotypically, that you need the triggers. And one of the biggest triggers is marijuana. So, if it makes sense to tell people to stay away, for me it does. It makes sense. Makes sense. A question here, please.
Listening to this wonderful work and going through, I'm seeing how the Ministry of Health will collaborate with Ghana Health Service, because we have the mental nurses, community nurses, but we don't have a psychiatrist. In Ashanti region, I don't know if the other region they have a regional psychiatrist. In Ghana Health Service, they are all linked to nurses. But if we could get a collaboration between what you are doing in Kolebu or wherever, together with Ghana Health Service, we will get people to really coordinate these things. Because we have the nurses in abundance, but who to direct and supervise them is also the problem. So there could be more work if we could get somebody as a regional or a district or championing these things in Ghana Health Service.
Yeah.
Where we find most of us in Ghana Health Service.
Right. So the unit in Kompanoche, who are they under? So Dr. Ruth, they are right. So I found a very vibrant group there, going through the fellowship and specialization and all of that. So the Mental Health Authority is supposed to have a mental health coordinator in each region and a district mental health coordinator. They are there. But I think we probably need to ask for, like you say, psychiatrists, and we need like regional psychiatrists, and we also need PhD level psychologists eventually, because you need to gather the knowledge. You know, we all think we know what's going on in psychiatric, in faith healing camps, but we don't. I'll come, let's see.
Yeah, I think I would like to know which antipsychotic drugs or medication did you use in the study? And then secondly, also, recently most of our community psychiatric nurses have a challenge. The medications are not available, and many of the patients are not able to buy them. And their medications are also not in the health insurance. So it put them at a very serious, so that most of them are getting frustrated in the system. I don't know whether anything can be done about these things. Thank you.
I agree completely with you. That was one of the difficulties we had. When we began, we said the medication was going to come from the Ghana Health Service. We would use only the medications available with the Ghana Health Service, and it worked for a while. Then the government stopped importation. So we had to buy our own medication for the 2 years of the study. And when they finished, we were referring them on, they wouldn't have access to the medication, so they would relapse. So this is a real problem. When we were helping to write the mental health law, I said at the time, put in a mental health fund, show the sources of the funding, so that government would automatically, like the Ghana Education, the GET fund, automatically send monies there. My colleagues were like, oh no, they didn't do it. So now we passed the law, and we didn't know where the money was coming from and now even so many laws, after we passed the mental health law, so many laws were passed after us that specified funding. And so government was funding all of these things, and then government has now decided that they can't fund all these things automatically because it doesn't make sense. They can't budget. These statutory funds go straight into things. So we've lost out all of these 5 years we could have, had monies assigned to mental health. But nonetheless, psychiatry in Africa is based more on medicine than on psychosocial interventions. And we need, and I'm a psychologist, but I know that for serious mental illness, we need medication. We need medication. So even though we don't have a fund assigned to that, we can go at it by saying that the Constitution demands equal treatment for mental illness as it does for physical illness. So we need to be able to go out there and negotiate good, low prices for our patients. So I think those are some of the interventions that are beginning to be thought through. So the medications, we used olanzapine, we used Haldol, haloperidol, we used amitriptyline, we used Prozac, whatever the doctors prescribed that we could lay hands on, which were accepted by the Ghana Health Service we used. Time is up. Okay, let me wrap up. Okay. All right. So we've talked about many of these things. We did find that patients do well on medication in a prayer camp setting, similar to strictly controlled hospital situations. We found that if you have community psychiatric nurses or medical assistants in psychiatry, the MAPS, you can keep people at home in their districts afterwards on these medications. Irregular supply of medication is terrible. Will CAMS cooperate? And we think so. We think this camp cooperated with us. We think CAMS will cooperate. We think that the way district health management teams can go in is to say, you are in our district, we're coming to check the kinds of people you have here. you can easily play a role, district health management teams play a role in making sure sanitation is okay in the camps, that people's rights are kept. But if you just go in and say, okay, I want to make sure there are no bed bugs in here, the people are not cramped, and so forth, that is your mandate. You can send your sanitation workers in. When you finish, you say, groups, collections of people here, I want to make sure that BP is under control, sugar is under control. You have all of these physical roles to play there. Then once you are in there, you say, the law says you can't keep anybody in chains for longer than 3 days. You have to send them off to a hospital if you have to keep them in chains. So you send them with a notice, then you report to the police. After 3 days, they have to go send them all to Pantan, Accra, or wherever, all the ones in chains. Pretty soon, they will not take anybody who needs to be in chains. So for this camp, we said, take them to Mampong, get them on medication. When they are calm, bring them. Otherwise, let them go home. Because people should not be kept in chains. Or, another intervention is to say, the district will make facilities available in the camp so that they're not kept in chains, but they can't run away and harm themselves or get lost or be lost. And then make sure that medication is brought into the camp like we did. So basically, begin to develop the community intervention places like mini psychiatric services camps taken care of by medical officers, nurses, and so forth. So this is what the model is. Fasting. The more you fast, the more you hallucinate, if you are hallucinating. So then you get more agitated, and then you get violent because you want to go away, you want to get out of these chains. They will chain you now that you are hallucinating and you don't seem to be behaving properly. And when they start casting out devils because you are hallucinating, you are more susceptible to their suggestions, and you begin to actually think that you are inhabited by devils and so forth and so on. It just is a vicious cycle. So that is something that you need to be aware of if you're going to go into the camps. And anyone who's on medication, of course, cannot fast. So you might just cut it out. And what we found is that there's very little teaching. When there is teaching, you can build resilience, you can build healing. We did some work in Tamale. This is what I said I would show you. Did some work in Tamale where we had groups of people who were well, and we taught them some things about mental health, about thinking, about bringing down anxiety, scheduling themselves, and so forth. And after 3 months, when we did our study again, we found out, this is post-intervention. The red is post-intervention. You can see that the number of people who report it's not mental disorder, psychological distress. The number of people who report no psychological distress goes up after 3 months. The proportion who say they're mildly distressed remains the same. Those who say they're moderately distressed, actually that goes down, and severe distress goes down even further. If you look at how productivity is affected, post-intervention again, people said that they missed about 5 days of work in the last 30 days, pre-intervention. Post-intervention, it's less than 4 days, just under 4 days. As a result of poor mental health, 2 days are gained, not missed. You can see 5 days missed, and then after after the intervention, they say they only missed 3 days. So just by putting people together, talking about mental health, that gains them 2 working days a month. Now, before the intervention, all around Ghana, the understanding or the calculation is just with this result of poor mental health, missing 5 days in the last 30 days. It's about 7% of GDP lost. If you are an economist, that will wake you up. But you are doctors, so it doesn't wake you up. Okay, so I think I will end here. And say that the mental health services are needed on all the levels of the pyramid. So I want to end with the pyramid, back with the WHO pyramid of services. I think that at all levels of that, we need to put in a little bit more attention. We need to teach people about mental illness for the base of the pyramid. And then we need to develop primary mental health care services, secondary and tertiary. So that's where we are.